Good afternoon and welcome to penultimate session of Hospice UK Conference 2023. Thank you very much indeed for joining us. I think you're going to find it's a really interesting hour that we're going to have, and we're very fortunate to have two guests with us from Uganda. We have with us Dianah Basirika and Roselight Katusabe. Thank you very much. Thank you. And we also have Emma Mathews from St. Luke's Hospice. We welcome you. We also welcome all those who are watching us streaming or will later be watching us streaming. We would like to give a special welcome to Dr. Anne Merriman, who is from Liverpool and the founder of Hospice Africa. Her name, maybe, Mama Africa. She has been an inspiration to all of us who have worked in palliative care in resource-limited situations. So we're very glad to have you with us. I'm going to hand over to Emma. And Emma, to explain what on earth is your connection with Uganda and how did it come about?
Brilliant. Yeah, thank you so much. That's right, I'm Emma and I'm a staff nurse at St. Luke's Hospice in Sheffield, and I was so fortunate I was able to spend 2 months in Uganda earlier this year, so February and March, and there are a few reasons why I went out. The first is that I'd just finished a project about advanced care planning in people who have myeloma. And one of the things that kept coming up in these interviews we were having is, we recognise that there's perhaps a real stigma around talking about death and dying, and a reluctance to talk about advanced care planning. And we kept asking ourselves in these interviews, I wonder what does it look like in other countries and other cultures and other contexts. And also, I wanted to meet my palliative care counterparts. I've flitted around the nursing world in oncology, hematology, oncology, all over. But I've really decided to commit to palliative care and dig my heels in. And like I say, I wanted to meet the people who were doing what I'm doing, but somewhere else. And as a nurse, one of my main motivations is the other nurses. It's the nurses I work with, whether it's fellow nurses on the ward, staff nurses who are just fantastic at what they do, or whether it's the nurses who are changing what it means to be a nurse and making advancements in practice and doing really impressive things in research, service development, pushing boundaries. And I love being part of something bigger, and as a nurse, I'm part of a community of 29 million worldwide, and I wanted to meet and to be inspired by as many of these nurses as possible. And that's exactly what happened when I went to Kampala in Uganda. So inspired by the nursing that I saw out there. It was at once holistic, beautiful, and also incredibly impressive in a very resource-strapped situation. And essentially, I've not stopped talking about my time out there, and the team at St. Luke's, they wanted to meet these brilliant clinicians and people and welcome them to Sheffield as I was welcomed to Kampala, and think about how we might start an international relationship with Hospice Africa. So I must thank St. Luke's and Peter Hartland, our CEO, who supported this project logistically, practically, but most importantly, very enthusiastically. Big thanks to Alison, who has meticulously coordinated this visit, and a huge thank you to Hospice Africa, who've spared 2 of their key players for a couple of weeks, and to Dr. Anne Merriman, who has been just such a champion of this from the get-go. So yeah, we've got Dianah here and Roselight, and they're both what we would describe as advanced nurse practitioners, and Dianah works mainly now in education, and Roselight is the clinical lead. And this session, you'll see we've just got all these pictures in the background to kind of show what the context looks like, to supplement our words. And as we're speaking, please think of questions, think about whether what Dianah and Roselight says does that align with the expectations that you might have had about what palliative care looks like in sub-Saharan Africa? Is it completely different? But yeah, please think of some questions for us. So yeah, we'll do it as like a question and answer. And firstly, Dianah and Roselight, I'd like to ask, how are you doing? You've been here for 10 days now. It's your first time in the UK. How's it going?
Thank you, Emma. I'm well, not complaining at least. Learning a lot of advance in healthcare here. So there is a lot to learn. And I'm acclimatizing to the weather.
Yeah.
Thank you.
Good.
Yeah, thank you, Emma. I'm also very fine, though I had issues with the weather being my first time to travel. So I'm getting well. I have learned a lot. I've seen a lot of experiences, and I'm pleased to see there is a similarity of the work we do in Uganda, though there is a difference in the technology and the high level of a health system you have here. Very excited to be here.
Oh, it's been such a joy having you, and I feel like spending time with you this week, I've seen Sheffield through new eyes. That's been wonderful. So second question is, why did you become palliative care nurses? What inspired this decision?
That's a good question. So I developed interest in nursing when I was still very young, I think at the age of 8, 9. And that followed my brother's health condition. He's epileptic. And all the time, I saw deaths happening and was worried if my parents died, how would I manage without my parents to manage the health condition? And so I decided that I would be a nurse to be able to help my brother out. But particularly my interest in palliative care developed because it so happens that my mom happens to be the first palliative care nurse in Uganda who worked along with Professor Dr. Anne Merriman. So I used to see the kind of work she would do, and I was so moved by the smiles she used to put on the patients' faces.
Oh, that's beautiful. Thank you. How about you, Roselight?
Yeah, thanks, Emma. Palliative care, if we all look at hospice and palliative care, passionate care in our systems, all of us are moved by something. So personally, I got very terrible experiences with my maternal uncles and auntie who died in very bad pain when I was still young. And first of all, I was motivated to becoming a nurse, such that I ensure that I take care of people who are suffering. And that time was during the very bad HIV/AIDS pandemic. And I was like, I have to be a nurse to ensure that people shouldn't suffer like how my uncles and my auntie are dying. So there I go in my nursing profession. However, that was not enough, because as a nurse, that time you were a bedside nurse. You don't really make any decisions. So, and there I was, I hear about palliative care, hospice care, and looking at the objectives, I'm like, oh, I think this is where I want to be. And that's where slowly by slowly, I went in, and I had in mind that I have my aunt who died in very bad pain, very bad wounds. For people maybe who have been in Africa, you've seen very bad wounds. And particularly my aunt died with very many maggots coming out of her leg and a lot of past discharge. Sorry if I distress any of you. So this is what I was like, no, it shouldn't happen. And I'm very happy that I am saving very many lives. I have put a smile on very many patients' faces. And I really feel proud being a palliative care nurse. And I can prescribe. Our government really has made it easy for nurse prescribers in Uganda who are trained in palliative care. So I was really motivated by what was happening in my family.
Thank you. And you mentioned the HIV and AIDS pandemic, which, yeah, let's talk a little bit more about why Hospice Africa came about in the first place, and that was in response to the HIV and AIDS epidemic at the time. Can you tell us a little bit about who, we've already mentioned lovely Dr. Anne, and why did she, what happened, how did it come about?
So you realize that in the early 90s, HIV was very high. the prevalence was very high, and many people were dying without, we didn't have ARVs, we didn't have antibiotics. It was difficult accessing antibiotics, antifungals, and if you did access them, you had the money. So literally, patients were dying in pain, in agony. And so at the time when Dr. Ann came, she thought there was something that could be done, and that is when she thought of starting a culturally appropriate service, palliative care service, to see that we could relieve these patients. So what happened is she gets into the hospital, starts working with the nurses that were on the wards, and she learned from the nurses who were there, particularly that was my mom at that time, who was the ward in charge. So she started working closely with her together with the other nurses. And slowly by slowly, they realized that actually the approach she was using was very helpful, relieving the suffering, relieving the pain of these patients. Oftentimes, what happened is these patients would be admitted in hospital, but because their pains were not managed, they would be told, please go back at home, we can't do anything. We can't do anything more. But the question was, if they went back at home, what was going to happen to them when they were already in distress? So by palliative care going into the community, being able to follow them up, that really improved their quality of life and relieved a lot of distress.
Okay, thank you. And you mentioned culturally appropriate palliative care. So obviously Dr. Ranch is an Anglo-Irish woman. She went over as a medical missionary. She wasn't, part of the Ugandan community at that point. Can you describe, what is culturally appropriate care? Maybe thinking, I found the way that pain is scored was really interesting.
Yes, first of all, a culturally appropriate palliative care is looking at the values, the beliefs, and the norms of a specific society, such that you offer a service that well fits them, and then they embrace it. It's very important when you look at people's culture, people's beliefs, people's norms of practice and traditions. So that's what Dr. Ann looked at. And interestingly, the international standard of pain score is out of 10. But when she came to Uganda, she tried to ask patients to score their pain out of 10, but then it got so tough for our patients. So whenever they would start counting from 0 to 10, reaching around 6, they would get lost. So she was like, no, I think I have to look for something that really fits them, such that we can easily know their severity of pain, then we are able to control it. So she broke it down to 5. So our patients started scoring their pain out of 5. So internationally, you multiply by 2, and then for us, we'd go at 5. And some patients, interestingly, still didn't, though everyone has fingers, but then they still couldn't get the numerical rating scale. We got the jerrycan study. I think you could see it running. So where we put the amount of liquid, jerrycans are, like everyone in our community has a jerrycan to fetch water. So like we know everyone has a jerrycan, and then the quantity of water gives the severity of pain. If it is very little water, that is very mild pain. If it is a full jerrycan, that is overwhelming pain. So, and however, even with that, there are some people in the community who don't pick it. So some of them will use stones, we count stones, or they can use sticks, or you use a kilo of sugar, like anything that a patient can really pick very well within their understanding, then you're able to support this patient.
Could I ask a question? Dianah, when I think of Uganda and palliative care and Anne Merriman, the thing that I always think about is food colouring and different strengths of morphine. Can you explain how on earth this happened?
Yeah, that's a very good question. So you realize that access to opioids is very difficult, has been very difficult across the globe, and it is even worse in Africa. So many of the countries in Africa can hardly access opioids for various reasons, myths, but also the stringent laws that do not allow prescribers to be able to use it. So Uganda was in the similar manner. And so when Dr. Anne Merriman came in, she realized that the difficulty that could pose when it comes to delivering palliative care in Uganda. And the condition was, if palliative care is accepted in the country, then the government needs to allow importation of morphine into the country. So given that she had worked in Singapore for some time, and they had developed a method of reconstituting morphine using very simple means, so she used that method and taught it to us, to we the Ugandans, to reconstitute. So generally, the way the morphine that we use is locally reconstituted in Uganda. So we import the powder, following definitely the INC board, the laws. So we import it and then reconstitute it just by the sink, a kitchen sink. We call it the kitchen sink method. So that's how we started, where you just get the powder, put in water. At that time, we were using boiled water, and then put in a color and a preservative. But definitely, that really was used to support patients within our facility. And this was really working out so well. But we realized there was a bigger need, and we needed to support other patients who are in the community. So the government embraced this, and since then, it has been able to take on the purchase of morphine, and it has supported us to stretch out to the country and be able to supply this drug across the whole country, and we have actually improved our method. So it's no longer just the kitchen sink, although we use the same kind of method approach. So we have now mechanized it.
And the colors, the different colors?
Yes, and the colors just differentiate the strength. So we have the 5 milligrams per 5 morphine, which is 1 milligram per ml, which we put a green color to show that this is the weaker morphine, 5 milligrams per 5. Then the stronger color, which is the 50 milligrams per 5, we put the pink or red color to differentiate from the other, and that is, this is stronger. And we had the strongest, which was blue. So blue was 100 milligrams per 5. However, as we got better with training, with better management of patients' pain and assessments, the blue morphine is no longer used because most of our patients get stabilized at the red morphine, which is 50 milligrams per 5. So the colors are just to differentiate the strength of the morphine according to the patient's severity and the response. Yeah.
And I know a lot of people, well, you might get clinicians from Europe or America or Canada kind of thinking, why aren't you using subcut medication? Why aren't you using injectable opioids? Can you explain how that wouldn't be appropriate?
So you will realize that with the oral liquid morphine, this is a drug that is oral, and you can administer it wherever you are. Anybody can administer it, as opposed to intravenous subcut, IM medications. So in palliative care, we encourage a lot of oral medications. So if we brought in the subcut, because I've been in the community while working with the St. Luke's Hospice, and I've realized there is a lot of use with subcut. It might be quite challenging for our patients to be able to administer this drug, but also looking at the disposal methods. I mean, we were trying to think of how are these injections disposed? How are these equipment disposed? And then how much training do the patients get to be able to administer this medication? So that can be quite challenging. And with the oral medication that we have found that actually very, very helpful, because at any time, with or without a caretaker, you can be able to use the medicine.
Yes, and we train these patients, we train their family members on measuring how, depending on how the patients have scored their pain severity. We train them, we give them the measuring cups or measuring syringes to be able to measure the adequate oral morphine they can take for themselves. We educate them. If there is a breakthrough pain, what do you do? And after that, we as well tell them the dangers of taking morphine like anyhow, because there are people who could get like overwhelming pain, and then they're like, let me put the bottle on the mouth and maybe I will have a better pain control. So we really educate them to ensure that we don't get such overdoses or misuse, and we've not had cases of having really drug addicts related to morphine. The only addicts we get are the ones who come from the community, and then they come to us for support to ensure that we try to mitigate the addiction bit of it as we work together with the other organizations that rehabilitate them.
Yeah, it's really a sort of sustainable approach that you're going for and trying to foster people's independence so they can, they aren't relying on their nurses as much. And then, Roselight, you mentioned something about nurses prescribing and it being one of the first countries to get nurses to prescribe. Can you tell us more, please, about the role of nurses as leaders in palliative care in sub-Saharan Africa?
Yes, thank you, Emma. This is interesting. You know, in Uganda, nursing is the backbone of palliative care, and the role of nurses is really interesting because as you train as a palliative care nurse, you are training to offer where there is no any other multidisciplinary team, because having a multidisciplinary team all through as you visit patients, patients come to you, is quite expensive, and it's really not very, very affordable. So a palliative care nurse is trained as a nurse, as a small doctor, as a social worker, as a spiritual leader, as an occupational therapist. Like, you have something to do for these patients. Always in palliative care, there is always something you must do for a patient to ensure that the quality of life is improved. So nurses are really very important, and as well as when you're when you're looking at this patient, you look at this patient as an individual. You look at this patient as a whole. You do psychological, social, spiritual, on top of the physical management, like our real medical nursing goal that most of the facilities do. So we go beyond that medical nursing. We go and look at the other areas that could be affecting the patient. And this is very well done by the trained nurses. And of course, as a nurse and as a trainer, when I train nurses and I go back to the community and I see they are doing this recommendable work and patients are at peace, are comfortable, we really feel proud as Ugandan nurses, as well as becoming prescribers. We really commend our government for having made us really allow us become prescribers, because we have a small number of doctors, though the nurses are also not very many, but we have small numbers of doctors. So if you were waiting for a doctor to prescribe like in everything and in our system, then it would be very, very tough for a patient. And then that is what would take us back to our patients dying in very, very bad agony.
Perhaps if I may add, nurses, as she says, are the backbone, but also you realize that they are doing the pain assessment, they are the ones doing the management. So they will assess, they will prescribe the medications. They are actually the ones teaching the doctors on how to do these assessments. So generally, palliative care in Uganda is nurse-led, and it is so happening across the continent, I think, now.
And again, we don't have gaps. If you visited hospice, there is no gap between a doctor. Of course, we have a doctor on the team. Where things get very tough for us, we take in the doctor we hand over to the doctor, and then we continue with the care. So most of our doctors, we don't have a gap between doctors and nurses at hospice. We work together, we have the same briefs, we discuss together, we listen to each other, we teach them as they teach us. So we really work together as a team. There is no level that this is a doctor, this is a nurse, this is a social worker, like we work together as a team. And this very model is what we also take to our patients. You realize when you come to us, we don't put on uniforms. We go to see our patients. We want to be at the same level with our patients. We want to be a family. We want to be friends, such that they don't have the other mindset that I'm in the hospital. And some of them, maybe with our settings, maybe there is some abuse in the hospital. They will come looking at you as a savior, to listen to them, to talk to them, not looking at you as a nurse, as a doctor, whom they will think you might be doing the same to them as what they faced before. So we really want to have the same level to ensure that our patients and us as the team work together in very good collaboration to ensure that our patients really get the very best quality of life that we can, despite our resource-limited status in the country.
Thank you. And could you tell us a bit more about what does the delivery of palliative care look like in Uganda? How does Hospice Africa work? How are the different modes of delivery?
So, generally, we are using 5 models of delivery. This includes home-based care. I'll categorize it into 2. So we have the community and facility-based. Under community, we have the home-based care, we have outreaches, we have roadside clinics. So while in the community, wherever you are, you can access these services. Is it by the roadside? Is it under a tree? Is it in the banana plantations? You've been seeing the pictures about banana plantations. The patients can access the care wherever they are. When it comes to facility-based, we also go into the hospital, and we have inpatient facilities, but we can have outpatient palliative care services and daycare services. So with the you can add more about the roadside clinic.
Yeah, and with the roadside clinic, we might wonder, we have an outreach whereby we go at a specific facility or a church or a school hall, but then during the roadside clinic, these are patients whereby they cannot reach where the outreach site is, and as well, we can't easily reach their home. Remember, we are going for the outreach. So, and we have a lot of hills, especially around our countryside. So some families are able to bring their patients closer, or patients are able to come closer. We see them from wherever they are. It could be under the tree, but then sometimes there is even, it is an empty space. So you have to roll a piece of cloth or screens around the patient. If there is need to examine, you examine the patient there. Though it also comes with its own challenge, privacy, but then at least you have done something for this patient that she or he wouldn't have accessed, and then you continue for the outreach. And this model has also been very, very helpful to patients, because most of the patients are not able to get transportation to come to the facility or even to reach at the outreach site. So when you see them closer to their homes, then they are at least able to get a service, and then their quality of life is improved. And for the daycare, we were excited. We found the same model at St. Luke's Hospice. We do, this is the psychotherapy and spiritual support to our patients. We get them off from home. We spend a full day with them. And then this gives a caretaker to rest, to have maybe some fun out, to do what the rest of their work. We relieve that burden at least for a full day of the caretakers, and then they're able to relax. And when the patients come to us, they're also able to share experiences with each other. It helps them cope, because others might tell them that me, I was in a very bad state, but now I'm feeling this better. And it helps them to cope and also to live a positive life.
Oh, yeah. When I was there, I've noticed just how much the care is so adapted to all the different communities, and people have so many different needs and challenges in accessing palliative care. And I think the roadside visit, that exemplifies that perfectly. And so you mentioned outreach as well, and you've been visiting these areas, like these areas of intense deprivation called the so-called slums, and working with community volunteers. Could you tell us a bit about that, please?
Yes, most of us here might not have seen slums, but we have very many slums in Uganda. And when it comes to the city where I work, it's really very, very tough. You find patients with both communicable and non-communicable diseases, and going to the hospital is a problem, and it is a very congested area whereby you can't easily go in and get to know which sick patient is here. So working with the community volunteers has really been very, very helpful. Community volunteers are lay people whom we train. We give basic nursing training. We give them protective gears to ensure that they go deep down in their communities and look out for these patients who need palliative care services, and then they call us or they bring their patients to us, and we are able to take care of these patients. And these community volunteers have to be well known in that community. So when they put on a hospice t-shirt, and then the local council governance is aware of them, because we go through the local council governance who tell us the people who are really able to do that volunteer work, then they are able to do it very well without any hesitancy in their communities. And they have been our eyes in the community, which has really helped many of the patients access palliative care services.
Thank you. Can you tell us about some of the barriers that these people in these communities face to, why might they not be accessing palliative care services? I remember there's a lot of fear around palliative care and superstition.
Yeah, but especially hospice and palliative care in Africa, I don't know how it is here, has a lot of superstitions. They think hospice and palliative care is for people who are at end of life. Hospice and palliative care is euthanasia. So they have getting oral morphine is reducing your lifespan, and then maybe they want you to die quickly. So it has all these myths and misconceptions. So even when patients are referred by their community or by the health facility, depending on where the referrals come from, these patients sometimes don't come. So this also poses a change to the team, a challenge, sorry, to the team, which goes to see these patients. However, with time, creation of rapport to these patients and explaining to them. And sometimes we take patients who can give live examples about their own health, and then they are able to remove this misconception and fears about palliative care. And also in the slums, it's very tough. Many people abuse drugs. They use a lot of drugs. So at one point, you really have to do a very proper assessment, which you go beyond, and even you ask the community leaders to look at how this family has been behaving in the community. Because if they're abusing drugs and then you give the morphine, you'll find their pain not getting controlled. And at the end of it all, they might even end up abusing the medication. So we do a very detailed, comprehensive assessment when we're taking care of these patients. And the other thing, there is a lot of communicable diseases, especially tuberculosis. So that also gives a big challenge to the teams when we go to visit these patients. So you also have to, you protect yourself as you also protect and help the patient. So when you first find out whether there is any coughing, you first assess for any risks of a communicable disease. And then you're able to support this patient. You have to devise means ensuring that you're safe, as well as helping the patient in a way, given the circumstance and the condition you find this patient or family.
In addition to what she has said, I'd like to add that I was at St. Luke's and I admired the facility. I actually said, oh my God, am I entering a hotel? And then I thought back of our hospice. It's a beautiful place, but it's uncomparable to St. Luke's. And interestingly, what we have come to learn that when the facility is very beautiful, it may attract a particular population and then leave out some. So like patients in the slums may not be able to come to your facility because that's quite advanced. So that is why we have devised means to reach out to them so that they can be in an environment that is culturally appropriate to them, that is welcoming, that they will accept. And so if a patient is not comfortable coming out of their garden, we go in. If they are comfortable to come in a very well-spacious place like our hospice that you're seeing, then they can also come to the facility.
Can I just remind you, you have the chance yourselves to pose some questions to Dianah and Roselight just through the Slido, if you'd like to. Emma.
One of the things, you've said it a couple of times this week, the term doctor shopping. Can you explain that, please?
Okay. Doctor shopping is much more of moving from one doctor to another. One thing I have appreciated while in the UK is the coordination that you have with your healthcare system. So once a patient goes to their GP, just enter the information, it's electrical, and then they will be able to get the whole information. As opposed to Uganda, we don't have really that electronic database where you can track the patient's information. So the patient will move from one doctor to another seeking for treatment, and unfortunately, they might get the same prescriptions from different doctors. They may have visited, say, 5 doctors, and they're getting similar prescriptions. They go to the pharmacy because for us, you can just get medication from the pharmacy. Just go and say, I need paracetamol, and you'll get the paracetamol. I need this antibiotic, you get it. So they will have this polypharmacy and these so similar medications, and before you know it all, they are overdosing themselves. But what palliative care has done is the more we go out into the community, we are able to identify these gaps and be able to support these patients to be on the right treatment that is appropriate for their condition.
Yeah, and secondly, to add on what Dianah is sharing, you know, in Uganda, I don't know, maybe across Africa, we have the people who call themselves doctors, yet they are not doctors, nurses, yet they are not nurses. So you'll find a herbalist calling himself Dr. ABCD, and they advertise very well. And then you find a spiritual leader calls himself Professor ABCD. So these patients go there to look for answers. Maybe they are in denial. They haven't believed that it is a cancer, so they go to a herbalist who will tell them, no, the medicine you're using, the medical interventions, the medicine you're using is not the right one. You're bewitched. So they go off that. They move from this herbalist, they go now to a spiritual leader. The spiritual leader, if it's not a right person, will also tell them, no, it is actually a witchcraft, but stop everything, I'm going to pray for you, you'll get well. We also had these cases with HIV/AIDS so much. Patients were stopped using antiretrovirals because they were going to be prayed for, or they are going to get a herb or any traditional medication, and they think they would get well. So doctor shopping is not like only the doctors, but now everyone calls themselves doctors just because they are looking for money, and then at the end of it all, our patients fall culprits, and by the time we get to know, they are dying.
You may not reverse the situation.
You don't reverse the situation at one point. However, in palliative care, there is always something you have to do for this patient. You at least control the controllable.
Thank you. And I remember when there was a shift I had when I was in Uganda, and we met 2 women, both completely separate cases, but they'd both been diagnosed with scans as having breast cancer a couple of years ago, but they'd both chosen different routes, so herbalism, traditional medicines, and then they both presented at hospice on the same day with advanced breast cancer. And then I remember there was the man with the bilateral leg wounds, and there was a constant dialogue between the nurses at hospice say, you know, educating about the importance of him taking his antihypertensives, but then he'd be speaking to a herbalist who was saying, stay away from the from your medication, you need to be taking this instead. So you're constantly having these conversations and this tension between the approaches.
Yes, and of course when they stop their medication, especially like this family Emma is sharing, this patient Emma is sharing, they will put these herbs and then you'll find a lot of infections, their wounds get necrotized. So getting a patient from this situation really takes a while, takes patience, takes passion. And then remember, you're doing all this in the community. If they have been in the herbalists, in the traditionalists, they will not accept to go back to the hospital. They will not. So you have to educate them, train them, and also show what they should be doing in your absentia such that the wounds get better and then they improve in case they have not got now chronic problems with their bones because of misuse of medications, failure to comply to medical interventions.
Thank you.
One of the questions coming in is, you've mentioned the word community quite a lot, and how you interact with the community, and you seem to make the community part of your team. Would you have any reflections for us here where maybe our sense of community is less? Do you think we should be using the community more in Sheffield? And if so, how could we do it?
Sure. Thank you for that question. You realize that in Uganda or in Africa, we have a sense of humanity. Like we have this word that we use, Ubuntu. Ubuntu meaning humanity, where we believe that we exist because you exist. We exist, I exist because we exist. So as a way, we have grown up or we live in a community setting knowing that you cannot be well if your neighbor is not well. The fact that our security lies in our community, we have an obligation at all times to see that your neighbor is well. So we, as a community, we usually have to mobilize resources to see that the well-being of our neighbor, of our people is well. Our healthcare system, if you want to access healthcare, is more of out-of-pocket spending. So different from here, where you are insured with an NHS. And therefore, if you cannot afford, that means you are likely to die with your problem even when it is curable. We've seen so many deaths of cancers that are actually curable, malaria that is very curable. But with the community engagement, with that kind of community, we know that you can run to a neighbor, you can run to a family member, and they will support you.
Yeah, and actually, they are ambulances for the patients. Before you call an ambulance, which might not even come, this community will have carried this patient to the hospital. And most of the communities, you will not find vehicles like there are many vehicles. You have to get someone or you have to call a special hire somewhere. But then there are some community whereby you find they will make sticks, they will get like kind of wood, wrap a cloth around it, and then they put this patient on that. About 6 men carry this patient on their shoulders until they take this patient to the hospital. So by all means, we have to live in a community, to live with the community, and then you have to also ensure that you're part of the community, that is the Ubuntu. So if you're not part of the community, then you might also not be supported if you get a problem.
And that explains our the use of community volunteer healthcare workers, the VHTs, we usually call them village health teams or community volunteer health workers, because they live within the community, they have trust within the community, and they are lay people. So they understand the systems, they understand the norms, they understand the language. So as a healthcare worker, I might be coming from another district. You realize that Uganda is multilingual. We have about 53 languages across the country. It's very small, but with very many different cultures. And all these languages or cultures behave differently. So having community volunteers who are within that area, these help us and guide us on how to approach different patients, different families with their guidance.
Thank you. There's more questions, lots of questions coming in. And one of the questions, when we worked in Nepal, we developed relationships with traditional healers. Some we could work with and some we couldn't work with, but we knew that most of our patients would go to traditional healers first. I don't know if it is the same in Uganda. And do you do any joint clinics, or do you work together, or how is there a relationship there?
So there's been a lot of learning when it comes to the use of traditional healers or working with traditional healers. In modern medicine, the Western medicine, where we have been taught as a nurse, as a doctor, this is something we've been told, don't believe in it because it doesn't work. That was in my nursing school. But what is so interesting is this is something that is embedded in our culture, that even when you say no, the patients will use it. And so what we have come to learn is how do we embrace the cultural aspect as we integrate our our modern medicine. So yes, traditional medicine exists and it works in most cases for patients. However, it also has its side effects. So usually our approach has been to assess how patients feel about it and see how best to work with them. There is a very big movement at the moment because there is a school actually for traditional healers in the country. I happen to have visited the school, which has quite a number of classes on how to use different herbs. A lot of research is still undergoing to assess how effective these herbs are in the management. But of course, many of the so-called traditional healers, spiritualists, sometimes are masking themselves and hiding, or just in the effort of making money, and they're draining, or they are using patients because they are in need, so they kind of make use of them so that they can get an earning. So we need to be mindful on how to interact with these traditional healers and support the patients appropriately.
Yes, and there is also some training we give to the traditional healers because some of them we know, and actually some of them pick interest coming for a short course palliative care training. Yes. So they come. Now these are the traditional healers who have gone to school, the ones who were educated, So they come, study palliative care, then when they go back, they use their traditional medicine, and when it doesn't work, or they work hand in hand with us. We also advise, we say, this one, because there are some medicines, herbal medications that we literally know that this is an opioid. Yes, so we tell them that now if you're using this, let's first hold our morphine. And then in case it doesn't work, we can come in. And then we say, for wound care, now that you have used the herbs, they are not helping, so can we try our medical interventions? And this we do at home. And we also educate these traditional healers to help other patients. And at the end of it all, those ones who have gone to school will work together with us. But then the challenge comes to those ones who completely don't believe in medical interventions. And so it now comes back to us to educate the patient also to look at what he or she has benefited from the other side, and what she has benefited from this side, and then she makes her own informed decision. And also sometimes if there is a high risk, especially with the traditional leaders, healers whom we call witches. There is a high risk of sacrifice, and then we really educate these families. We give them information, and they make an informed decision. There are some, like what is running now. This herb here is a frangipani. So its sap is very good in relieving neuropathic pain secondary to herpes zoster. So when a patient comes with its very this very painful rash secondary to herpes zoster or neuropathic pain, we get this sap, and before before you clack this patient, you quickly add that sap on the rash, and then you let the patient rest. Then you give your start dose of morphine. Then you're able to clack your patient. So some herbal medications really work, but it depends on how you use them and the belief you have in them. Yeah.
Thank you. Can I ask you a difficult question? I come from Northern Ireland, where we've had lots of conflict. I know Uganda has had a lot of conflict too, and you have refugees, and you have people who have been through really hard experiences. Does the conflict that Uganda has been through, and the aftermath of AIDS, and the aftermath of Idi Amin, the so many things which have happened, has that affected the delivery of palliative care? Does that affect some of your patients?
Definitely yes. Thank you. Definitely yes. That to some extent does affect the delivery of our care and the quality, because one, we'll get massive numbers of patients needing the services, but we don't have the resources, so we struggle. You realize that many of our patients are not just Ugandans, they're not just the nationals, but they're coming from all over Africa, and all these need services. And given that there is no limitation on how to regulate, you need to intervene. So definitely it does really affect us. And emotionally, it's quite very draining, knowing that there is a war, there is a conflict somewhere, and you as a healthcare worker, you've got to be on job to deliver the service. Emotionally, you're not settled, but you've got to be there. Thank you.
Yes, and this as well kept patients with a thinking and with a fear that if I leave my own area, my own community, to another place, like our patients move 300 kilometers or over 300 kilometers to come and access treatment in the center where we have a national hospital, which is in central Uganda, where the capital city is. So patients start thinking, there was a bomb blast around that time in Kampala. I'm not going there. So patients remain home because of the instability. And even when you try to support as hospice, you really want to bring them to the hospital. They will think of the instability, the conflict that has happened, and they will not come. Others will openly tell you, but others will say, let me go back home, prepare myself, and you'll not see them. So it really causes a challenge too.
And with that, you realize that many of them, their diseases will advance. Even when you think it would be curable, it becomes incurable because of inconsistency in the treatment.
Yeah.
Thank you. Can I ask a couple more, Emma? Is that all right?
Yeah, you go for it, of course.
We have Kate Fleming from York and Annette Alcott asking, how do you adapt your services for working outside of Uganda, or how do you adapt your services for working in particular cultures where maybe it is not so easy to use morphine or to work as a nurse in the way that you have described?
So you realize that our vision is to see that palliative care reaches all to those in need in Africa. And we use our model in Kampala to support other African countries to do this kind of work. So what we do is to do a needs assessment, because we don't know what is existing in the country. So once we get a request on support, we then work with the persons who have put in the request to assess the needs and what is needed for us to intervene. And once we know the needs, then we design the services appropriately to meet these needs.
Thank you. A couple more questions. I'm going to read this one out. You and your teams are absolutely awe-inspiring. You face similar struggles and more so with a fraction of the resources and support structures that we may have. Having seen palliative care in the United Kingdom, what do you think you will transfer back to Uganda?
Yeah, definitely here the standard is really very, very good with very high technology. However, we have looked at, this is going to be kind of advocacy because you can't just roll it out. It's going to be part of advocacy. Like how we have seen the way St. Luke's works connects to the district nurses, to the intensive home care nurses, and we think we shall have an advocacy through our umbrella organization to at least ensure that we get a way of how we could have community nurses who could be like the district nurses in future, such that without us, the hospices, they can also be supportive to these patients. And of course, with the technology, like everything here for us, everything you use your physical energy, carry a patient, carry this. But here we've seen good, that technology will come maybe in future, but basically now it's advocacy to use our district services, our decentralized health facilities to ensure that at least they are very supportive. Even without us, we can just give a call away and then they are there for our patients. There is a way you have a very good connected service here that really is not very well connected with us. So like a hospice nurse is everything. You even have to carry your patient to the hospital, look for the doctor, ensure that this patient is comfortable.
Dianah, I'm going to give you a tougher question.
No problem, if I can.
What are you definitely not going to take back to Uganda?
Oh, be careful.
Thank you so much. The simple response to that is thinking about the advanced resources and having to lobby for these advanced resources to come in when I know we don't have the monies to start these resources. But I don't know why this is not working.
It's okay.
But anyway, what is quite important is we have seen your data, not seen the data. We've seen your tools on how you collect data, and these have been very informative. And we think we can adapt some of your tools to start with and be able to utilize our data better, perhaps through research, but also perhaps through collaborations as we continue to better our services. We may not be able to do exactly what you're doing here because definitely your culture is different, your resources are different, but we'll try to do what we can.
Yes, and we also saw the ECHO training system, which is very, very educative for people who cannot reach the physical training. And then they have these continuous refresher courses around the other teams, which is really very, very helpful.
I didn't pay Roselight to say that. We have... can you tell us, moving forward, Emma and Hospice Uganda and St. Luke's, are you planning to collaborate together? And is there a place for people like Emma coming to Uganda? Is that accepted? Is it helpful? Do you feel encouraged by that? Or do you feel discouraged by it. There is so much history of imperialism and negativity and being objectified and all of those things. Is there a relationship which is valuable between us?
I think that was something going out. I was so, we've all heard of the white savior and people, people from Europe and America, they go to all over the world and they'll build a well and knock it down and take pictures with poor children. And it was something I was really conscious of, and I had to think a lot about why would I be going out? And I suppose the team, they didn't need me at all. I wasn't filling a gap or anything, but it was more creating a relationship, sort of sharing, learning about how you do things, sharing how we doing things, and thinking about a sustainable relationship going further. It would be about an equal relationship, and so we're looking at perhaps doing a bit of research together. And at Hospice Africa, there's a burgeoning research community and culture developing a lot. I mean, you want to do a PhD, Roselight, you're just finishing your master's, and a lot of the other nurses. So thinking about how we might collaborate with some research, and just been very sensitive, and like you say, the colonialism, and it can be really problematic.
And just to add that with the collaboration with the St. Luke's, we believe there are still more opportunities because there is so much to learn, there is so much to do with while at Hospice Africa Uganda. So yes, we are open to more collaborations because we believe everybody is skilled, everybody has a talent. And if we share this, we can be able to support many more and learn from each other, not only in Uganda, but also wherever you are. So you're all welcome for the collaboration.
Yeah, and we really, as a country, we don't limit volunteers, both local and international. So Uganda is a country that really has survived on a lot of volunteers. And us as hospice, we have really benefited a lot in local and international volunteers, mostly international volunteers. So both nurses, doctors, other professions, everyone at least has something to do, because we have very many activities we do apart from the patient care, like clinical care. We have research, we have training, we have a whole institution which trains up to the master's level. And there is muffin production. Like everyone at least has something to add. Documentation, making us, our documentation and reading in Africa, I think across, is not very good. So maybe we can also learn something more to make our work better, to have our documentation better, and this all, at the end of it all, benefits the patient that we serve.
Roselight, Dianah, Emma, thank you so much. You are shining examples of what nurses can do. Yeah. Could you join with me in saying thank you?